utilized. And what you see here is in the darker areas represent areas where people are simply more likely to die in a hospital based on their residing within that area. Now, I don't know about you guys, but if somebody told me that where I was going to die was going to be impacted by the zip code in which I was living, I would be a little concerned. And right now, that's the way things are. Next slide. Medical expenses, as you know, are extremely high and rising, and for patients like those who are on ongoing maintenance dialysis, this is quite evident with numerous doctor visits and numerous complications, the need for equipment, support in the home, et cetera, et cetera. And medical costs do remain the #1 cause of personal bankruptcy across the country. Next slide. So when we look at the way we're providing care, for example, from information in the Death Atlas, and we look at whether or not days in the ICU or days in the hospital or numbers of hospitalizations in the last 1 to 6 months of life, whether or not any of those activities or occurrences improve survival or lead to better quality of life for patients, we see that they do not. So another way of seeing that is that patients who have higher access to intensive types of care towards the end of life do not actually do better. Next slide. Their experiences, however, are much, much different. And this is where we kind of get into the quality of life, patient values type of information. Patients are getting more aggressive care. That would certainly make sense. They're seeing more specialists more frequently and so on. They're spending more days in the hospital. But the flip side of that is that they are feeling sicker. They are not spending time at home with their families. They are not able to create or envision or plan for a quiet end-of-life experience that they might be hoping for. Now, of course, many patients do want to receive very aggressive care right up until their very last breath, and that's fine. But what's happening right now is we're simply not asking and not finding out. And so, as you know, people get on that conveyor belt and they just like the train into the ICU and out again. And that isn't necessarily in their best interest. Next slide. So let's talk about how we do some of this planning and why it makes a difference. Next slide. Goals of the planning that I do with patients are really to help everyone on the care team. So this really is a service to the healthcare professionals as they work to guide their patients. It also is going to assist the patients and families to express truly informed choices, and I mean that in the sense of informed consent for the medical care that they are getting in a way that is centered in their values. And overall, I want to strengthen the entire healthcare environment so that everyone has access to that kind of conversation and those kinds of opportunities that will be making a big and positive difference for them. Next slide. This is a quick overview of, one way to think about how advanced care planning can work in a healthcare setting or for an individual. And we certainly believe that advanced care planning should begin for any adult with starting to choose a decision maker that would speak for them in the event of, for example, a traumatic accident or a brain injury, and that if they've chosen that person carefully, that they legally empower that person by completing an advance directive. And when you're young and healthy, really that's all you need to do. You might want to put some thought into what kind of care you would want if you had a severe brain injury or you were in a persistent vegetative state, because for young healthy individuals, most likely thing that's going to happen to them is trauma. As we age, and we develop problems related to aging, or we develop diseases, disorders, things that are really going to impact our quality of life and our daily existence, then we want to look back at that advance directive. We want to update it regularly, make sure there haven't been any changes in the family or deaths or births or adult children who have become capable of speaking for their parents and that sort of thing. We want to update it, and then we also want to bring in some of the prognostic and medical information that might be needed to support patients in making decisions around their advanced care planning. And then when they get diagnosed with a very serious or a chronic progressive illness at any time or stage of their lives, or as we advance towards very old age and we simply become frail and more at risk of dying or having life-threatening events, then advanced care becomes much more important, really a critical process. The conversations become richer, deeper, and certainly often more emotionally impactful. Ultimately, down the corner on the right there, you want to see that everyone's wishes are honored. And how we do that is by keeping the information within the system and also within the circle of care for the family, and fundamentally supported by the documents that we need in order to do this work, which would include an advanced directive post form, as you may know. Next slide. So what really is advanced care planning? Really a process, as you saw from that slide you just looked at. It occurs over time. It is not a discrete event. It never can be just a one-off checkbox thing. It's really a touch point for every visit and every time the patient comes in and cycles through the healthcare system, to be sure that we are on target and we are providing care that's consistent with their values and goals and preferences at all times and along the continuum care, and definitely when there's serious illness or end of life is on the horizon. Next slide. Another way to think about this graphically, and this is kind of a big slide, but I really like it because it shows a couple of different things. If you look at the main body of the graph here, you're going to see sort of to the right on the screen where you see it is when you're well and you're healthy. And that was for that upper right-hand corner of the other graphic we just looked at. And the activities of advanced care planning, you see it in the gray box at the top there, are really just quite basic. You're doing some basic advanced care planning and you're filling out your advanced care directive when you're a healthy adult. Then when serious illness is diagnosed or things are starting to happen, the focus of palliative care begins to come in. The reason we say this is because palliative care is fundamentally interested in providing care that's consistent with its values. We're still providing care, curative care, maintenance and management care to keep the person functioning alive and well as long as possible. But the conversations now start to become a little bit more serious and a little bit more intricate and a little bit more definitive in terms of the way we talk about the potential treatment options. And then, of course, as you move further to the right, the conversations, you'll see up at the top in the blue box, really anticipating of life at that point. We're talking about whether or not a post form is indicated. If it is, we will offer it to the patient. We want to understand what they would want in the event of a life-threatening event. Why is that? Because if they're likely to happen, we want to know what they want us to do if and when they show up in the emergency department, unable to speak for themselves and in need of life-sustaining treatment. And that's for both, really. Certainly speaking as a physician, I can say how lovely it would be to know what someone wants when they're about to go. And I want to know whether or not they should be intubated, whether or not they would want their heart, want me to attempt resuscitation if their heart should stop. And I don't know, and I'm making a decision in a void, and the family is also unaware. That's a very stressful situation that we can avoid entirely by having good advanced care planning. And then far to the right, the last part of the graph, of course, we're going to continue to provide support for the family and appropriate bereavement care. And that usually comes through the hospice mechanism. And that's really important for patients and family members. Next slide. So according to the SAS, the definition of palliative care is patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. And when we talk about suffering, we really want to remember this very important fact that only a patient can tell you what suffering is. for them. It might be physical pain, it might not be. It might be stress related to work or difficulty sleeping or any other of a number of symptoms which we would aim to manage for that patient in the interest of supporting their best quality of life. Next slide. So patient-centered care really is palliative care. If you think about just generally the best type of care that you could have at any time in your life, it would be palliative care. It's when someone asks you, hey, what's important to you? How do I choose your medical treatments, whether it's an ankle brace or blood pressure medicine or cardioversion? How do I choose these treatments so that they help you to live the best life that you can live according to your own definition? And obviously with palliative care for those who are in serious illness or chronic illness, we do spend a lot of time focusing on symptom management and maximizing the activities of their care circle. It could be their family, could be their friend, could be a nurse assistant, could be an in-home caregiver, and so on. Next slide. Palliative care, when it's delivered, is always multidisciplinary. Most of you know that. It's team-based, so we're talking about very often a physician provider or mid-level provider such as an NP or an advanced practice nurse, along with usually a social worker who is skilled at palliative care, a chaplain, a psychologist, there might even be a pain specialist. There could be any other adjunct people to that team as needed depending on the situation, but it's fundamentally based and crosses all the spectrum of potential patient needs. Next slide. So once again, to sum up that first part, the heart of palliative care is advanced care planning. And the reason that is because advanced care planning at any time is a set of conversations when we're talking with the patient. And that is just really, really a critical thing to understand. And to think of those conversations, I actually call them an intervention. It's not just chatting. It takes some skill to do this well. And it's something that can be learned and practiced so that you can increase your efficiency as well as your efficacy when you're having conversations and you're needing to get information from patients about the types of treatments that make the most sense for them. Also, of course, we've got symptom management and support for the entire family and patient. Next slide. So now we can focus a little more on end-stage renal disease and looking at what happens for some of those patients and maybe think about why talking about quality of life and bringing in some of the concepts of palliative care is really so very important for the population that you serve. So end-stage renal disease is quite unique. It's an illness, generally speaking, without cure when the kidneys really start to fail, and survival is all over the map. We've got young patients with congenital issues with their kidneys. We've got older folks who suffered an insult to their kidneys. We've got kidney failure for all different kinds of reasons. Some are very well otherwise, physically, with primary kidney disease, and they may live for quite a long time while getting dialysis or other support services or after a renal transplant. And others have a heavy, heavy burden of comorbidity, and end of life might come within days or months or years. So the care that we give and the way that we give it to these quite different types of populations of folks with kidney disease really cannot be one size fits all. And I hope that's pretty obvious to you all as you see your patients coming in for dialysis or in the outpatient setting. They may all have kidney failure or kidney disease, kidney functionally impaired, but they all are leading different lives of different levels of quality of life and different levels of activity and functionality. Next slide. You are not alone in this work. I just want to remind you that others who focus on renal disease generally and also broadly nationally have been spending some time thinking about this, thinking about how we can engage patients with renal disease in advanced care planning and help them to understand what they might gain either from palliative care or hospice. There's been work done on this. This is one example of that put out by the Southern California Renal Disease Council. And this is a good guide, and it has information about health directives and is available to you all. Next slide. This is even a more in-depth look at what I mentioned earlier in terms of kind of informed consent about the care that we give, shared decision-making, and the appropriate initiation of withdrawal from dialysis, a clinical practice guideline put out by the Renal Physicians Association. I really like this reference. I encourage any of you who are interested to track it down. It's available as a PDF. And this has a number of really good, helpful sections and focuses quite strongly on these types of conversations, when and where and how, and also what some of the content is that needs to be covered in the conversation with your patients. Next slide. The topics are covered. I listed some of them here. These are kind of like little mini chapters in that guide. How to establish a shared decision-making relationship, how to facilitate advanced care planning, making the decision not to initiate or even making the decision to discontinue dialysis. What do you need to think about? What do you need to talk about? Number 4 there, resolving conflicts, and then providing effective palliative care. And these are all covered in that nice guideline. Next slide. So what are the elements of the conversation? These are some of the topics that you might cover if you were engaging in an advanced care planning conversation, or another way to phrase that, shared decision making around the care that the patient is getting, and trying to understand if that care and those interventions are matched to that patient's values and beliefs and the way they want to live their life. So you might talk about any one of these things. And of course, this list is not exhaustive. There are many other things you might chat about in the context of that conversation, and many important pieces of information you might document that could help either other members of the care team or future members of the care team in understanding that person's choices and helping to make decisions at a future time, which is really an important aspect of this work. I do want to point out the bottom bullet point there, trade-offs folks are willing to accept. You know, it's easy in our westernized sort of world of entitlement that, you know, we all would like to have everything. And patients come in, you know, we often sort of think of healthcare sort of seems like this big smorgasbord, this buffet. I can have some of this and some of that. But in fact, we know that some choices preclude other choices. And we need to help patients understand that. And as their choices maybe become limited, for example, we might not be physically able to tolerate a surgery or a transplant at a time when you might want one. Helping them to understand what their choices might be and what trade-offs they are making when they are asking about a particular choice is really, really important. In other words, we sort of have to remember to tell the other side of the story. For example, you might be discussing about initiating dialysis in a situation where the outcome is quite uncertain. It is equally as important to discuss what would happen without dialysis and what would be the potential downsides, as well as the upside of any treatment intervention. Next slide. So important key actions that pretty much everyone should do, everyone of your patient should have the opportunity to do sooner rather than later, is to spend some time thinking about and choosing a trusted decision maker. And there are lots of handouts and stuff on our website that can help them do that. We know that trusted decision makers have certain qualities. They're usually available. In other words, they have a cell phone. They don't have to be in the same town, but that's handy if someone is coming in and out of the hospital. They know the person's values. They're going to be able to speak in the voice of the person without having their own personal values and wishes intrude upon that process, even if that decision is something they might not agree with. These people, these trusted decision makers, also probably should be folks who are comfortable in a medical setting. You don't want folks who have a lot of white coat, high blood pressure, or anxiety every time they walk in a hospital or smell a disinfectant. That person is going to be struggling to make difficult decisions at the bedside. So there are lots of things to consider when choosing a decision maker. We see very often someone sort of does a knee-jerk reaction of picking their spouse or their, someone who's very close who just seems like the natural choice. But when you start actually looking through a good checklist for a trusted decision maker, you find that that person may not be quite the right person. Very often, for example, in the setting of, say, a married couple or a spousal relationship, the person that's closest to the patient may be the one who really is struggling the most with an anticipated loss, and quite honestly, maybe emotionally overwhelmed at the time a difficult decision needs to be made, particularly with respect to life-sustaining treatment. Next on that list is empowering that person. So the person gets empowered by understanding and having an opportunity to discuss with the patient what their goals and values are, and sharing that with the healthcare team. And next, discussing unacceptable states of health. So again, this is a really important question that often does not come up in the context of a routine clinical visit or a routine health visit. And what we want to know here is, gosh, are there any situations you could imagine yourself in that just would be totally unacceptable? In other words, you would never want to go through that. And someone might say, well, I don't want to live like a vegetable, or well, I don't want to die hooked up to machines. And when we hear those phrases, we need to unravel them. We need to unpack them. We need to understand what it is exactly the person is concerned about, what they want to avoid, and how likely that is to happen, and to discuss that with them. Next slide. What is hospice care? So you're all familiar with hospice, I know. It's comprehensive care at the end of life. As you know, these days, it's really sort of almost purely, you hear that term and you think of it as two things. It's a system of care that is comprehensive and system-focused and team-based at the end of life. It is also a very well-described medical insurance benefit for which people have definitive eligibility or not. And that is based on their prognosis. I know their primary treating physicians or consultants or specialists need to agree that they probably have about 6 months to live. And we all know that we're just not very good at prognosticating, but we usually can guess when someone is within 6 months plus or minus. And all of those folks, and anyone really who's even a bit upstream from that, you have the opportunity to learn about hospice care, even if it's not quite time for their referral. It's something they should learn about so they know when they might want it, for example. Next slide. So Medicare is a hospice benefit for those who are on dialysis. Requires that they have a 6-month prognosis from a non-kidney disease, all right? So some of your patients who have been on dialysis for years and maybe more recently diagnosed with a primary or a secondary tumor, they're undergoing treatment, maybe that isn't going well, you can anticipate that they might be eligible for hospice care while on dialysis if they are expected to die or to have a shortened life expectancy due to a non-kidney illness. And 6 months prognosis often means you have to give up certain other treatments, but these patients can get dialysis. Other patients who are dying from complications of renal disease have to discontinue dialysis as they enter hospice. Now, there's always some debate about this, and at any it might change. So it's worth sort of picking up because you care for these patients. You know that there's kind of a palliative component to dialysis. It doesn't just quote unquote clean out the blood and adjust electrolytes, but it helps patients to think more clearly, maybe reducing their nausea. There's a symptom management piece that's going on there that may provide benefit. And maybe one day we will be able to continue providing intermittent dialysis for symptom relief, the same way that we do provide palliative radiation treatment or palliative chemotherapy that's designed at reducing pain, and sometimes are ongoing during hospice care. Next slide. So researcher list, we've talked about a lot of these different things. This is kind of a bullet list for you to be able to look at and think about, have I touched on all the things that I really need to think about when I'm planning, helping this patient plan for serious illness or end of life? And again, not an exhaustive list, but it shows you, I think, the breadth and scope and depth of the conversations and the activities around advanced care planning for those with ongoing serious illness. And it should be very clear by now that it's really too much to leave for too late. The earlier we start these conversations, the more we support the patients to gain the language and to be empowered to talk with us about these issues, the more effective and beneficial these conversations will be. But if we leave it all till the last minute or until someone ends up in the ED or the IU, it's too much to cover at that point, and it is being sort of emergency planning, and really that's not good enough anymore for the patients we really care for. Next slide. So I think I already mentioned this for you guys, but so any patient from a symptom burden with renal disease is appropriate for palliative care, obviously. I think that goes without saying at this point. And then as you looked at on the previous 2 slides ago, patients on dialysis may be eligible and might have hospice care if they're seriously ill from another disease process that can be identified to be the cause of a 6-month prognosis. Next slide. This is a study from a number of years ago that looked at how advanced care planning changes the care pathway for patients, and patients were offered the opportunity to participate in advanced care planning to discuss the potential benefit of continuing dialysis or not continuing dialysis, and to learn about hospice. And this was particular focused on looking at folks with sort of chronic failure to thrive. Those folks, when you see them walk in the door, you think, wow, gosh, I'm not sure how much longer so-and-so's going to be with us. And what they found was that patients were interested in not dying in the hospital. They were interested in avoiding certain types of suffering. There was interest in using hospice, but that for the folks who didn't have the opportunity to engage in these conversations, they were almost uniformly not enrolled in hospice, and most of them died in a facility. So if we don't talk with patients about what they might want, we really do not have the opportunity to make a different plan for them, even when a different plan is what they would want. Next slide. So how do we know who's going to be ready for a hospice discussion, or who's going to be potentially eligible for hospice? And how do we think about starting and stopping dialysis when we know that somebody is really potentially quite frail and may be suffering from significant comorbidity? This can be really a challenge. So patients with terminal illness other than advanced renal disease, as I mentioned, can be referred for hospice evaluation. But I think all patients on dialysis with any significant comorbidity really are deserving of and appropriate for at least consideration of palliative care services if those are available, and in the very least, looking at their care through the lens of palliative care. So maybe you don't have a palliative care social worker on your team, and maybe the nearest hospital is a ways away, but you can use some of the concepts and interventions that are the heart of palliative care to provide that primary palliative care for your own patient population. Next slide. Graphically, the approach might look a little bit like this, where you start dialysis, folks are, somewhere along the timeline of life and death, but then as their prognosis is getting more serious and end of life approaches, we're going to change the focus of what we're doing. In other words, early on in dialysis, when the patient is well, we're going to focus heavily on specific medical metrics that help us to know that the dialysis is doing its job, and we're going to try and get that person fully rehabilitated and back into working life and so on. But then as time goes by and they are suffering more from their underlying disease, our goals at that point should shift away from the numbers and much more towards what we call patient-centered metrics, and that might be effective pain management or minimizing other symptoms or maximizing functionality or perhaps maximizing time at home away from the hospital. And those are patient-centered metrics that can become actual goals for the medical team. Next slide. So I think, these slides get a little bit busy, but, there is a way to approach this systematically. In other words, you have your own internal little checklist that's part of your advanced care planning process. And again, this is where I say practice makes improvement, and that we can become more efficient at bringing up and discussing these topics, develop a greater understanding of potential interventions that are going to support the patient, developed more facility for shared decision-making and informed consent around the treatments they're giving, and regularly assess whether or not the prognosis is changing and whether or not the burdens of the disease or the wishes of the patient are transforming, and to remember to offer a pulse form and to be skilled in the way that we do that, to create a quality form that actually represents the patient's wishes based on their values, that makes active use of limit trials of therapy when indicated, and that it's backed up by appropriate documentation in the medical record, so that if anyone has questions about that form, they can go back and they can see, oh, I see here that a very thorough discussion was held with this patient and they made an informed choice about this option. And then last, of course, we remember to educate them about hospice in advance of the need of it, and consider making results in a timely manner. Next slide. Just a reminder that patients who do have a pulse form, they can be DNR and still receive full treatment. There's still a lot of confusion about this, but DNR in its most basic form means if somebody is not breathing and their heart is completely stopped, you're not going to shock it and you're not going to do compression. And up until that, you can do pretty much everything. So they could go to the ICU, they'll be intubated, they can be on IV antibiotics, be on IV pressors, they could be getting CVDH or active dialysis. But when their heart stops, and they're going to die unless you do chest compression, the cardio electric shock, then you're not going to do that thing if the person is DR. Next slide. So here's just a quick example, because I really, really care about the quality of pulse forms. If someone has chosen full treatment, be sure to help them understand that after resuscitation, what would full treatment really mean? Or would they want that to continue indefinitely being, kept alive by medical means? Or would they just, or would they be interested in considering a trial period where they might get full treatment for a while, but if it wasn't helping them to achieve goals that were important to them, like getting and going home again, that there would be an opportunity to redirect care and to change code status or whatever was appropriate at that time. And when you fill those out, to remember to really document in the chart what's going on there. And as you see on this example down at the bottom, one good sentence can ease a lot of consciences. So if I see a post form and someone has chosen full treatment and I say, that's interesting because I know they have a life-threatening disease and they're really high risk to spend a lot of time in the ICU, what were they thinking? And I see they've chosen trial period. Well, that helps me to understand they're thinking they wouldn't want to be in the ICU indefinitely. But when I go and I read the chart and it says, well, patient said, I want to avoid long-term hospital or ICU care if I no longer indicate my personal preferences and I can't communicate with my family. Okay, I get that. I understand that, and I can take that information and create with the family a care plan that makes sense for that patient. So you see how, I hope, how that one sentence can really help me understand what that patient was thinking when they made those choices. Next slide. Okay, so palliative care within the dialysis facilities. These next couple slides outline a process that you might implement. This comes from Dr. Moss, who's just done a ton of work in this area. He's a great advocate for kidney disease patients of all types. Number one is to create that palliative care focus, to bring that terminology, to bring that knowledge base into the dialysis unit, really kind of at every level, and to think about doing that systematically and through process, using quality improvement activities, using the would you be surprised if the patient died question, because we know that's actually been validated in the literature that if you answer no to that question, that person is well, they're eligible to have post-form discussion. They're eligible for palliative care. They're eligible for a lot of things, and should really have the opportunity to express their goals and values. You want to create a network using these concepts with your local hospice programs and other care providers in your area to cover all bases and to ensure that the patient can have a team-based approach or the types of care needed when the need arises. Next slide. So this is a continuation of that process that Dr. Moss was describing. Number two, outside of what we just mentioned, would be a focus on pain and symptom management and having particular tools and protocols for doing that. Number three, systematized advanced care planning. And when I say systematized, I mean everybody knows how to do it. Everybody's skilled at it. You all have the resources. You know where it's going to be recorded, and you can find the information when needed. Psychosocial and spiritual support, terminal care protocols, and bereavement programs for families for the folks that are really in the last phase of their illness. Next slide. This is a reminder that, a lot of times people get started on dialysis and it's not going to help them. I'm sure you've seen that before, particularly frail elders and those with comorbidities. In fact, their quality of life, even their longevity, may be diminished by starting dialysis, even when it appears there's a clear medical indicator to do so. And there's some interesting information available on this in the literature, but we just know that some patients, their kidneys might be on the way out, but if you start them on dialysis, they're actually at very high risk to do worse. Quality of life to go down, and also functionality to go down. So really important question to ask, is dialysis going to work for this patient to help them achieve the goals that are important to them? And maybe the goal is as long as possible. So maybe the goal is just as much time at home, or go golfing, or go gardening, or something else. Next slide. Talking about prognosis, this is really a tough one, right? We have so many different ways that we think about it, but talking about it with patients and helping them understand the uncertainties around it and yet also be able to plan is really important. Next slide. Lots of different ways to measure and lots of different numbers to look at when you think about how are we going to anticipate how long the patient might live. And you can get lost in those numbers, and those numbers don't necessarily help you. So it's important to think broadly and remember that the would you be surprised question is very helpful. Next slide. And just a caution, don't initiate dialysis or life-sustaining treatment just based on a number or stressful situation. We should all be taking the time to really talk about and create an opportunity for shared decision-making that allows us to identify the patient's and the family's essential goals and values and to try to create a care plan that will help them to reach those goals and values in the best and most productive way, provided that is medically indicated and reasonable. And then also importantly, to help them specifically to avoid some of the harms and side effects and burdens that particular treatment plans may bring about. Next slide. So how do we do it? Well, we have to talk to the patient because we can't create a care plan that's appropriate for them if we don't know what's appropriate for them and in the context of their life values. And we definitely do not want to leave it until we can't talk to them anymore. Next slide. It's about the people, as you know. This photograph actually comes from a nice little video that's available on YouTube that sort of walks through a family making some tough decisions about renal disease, and it's kind of helpful, and it might be something that you would want to look at or maybe share with patients or families as a way of opening the conversation. There are lots of different techniques to use for opening conversations, and if you haven't had any training in doing advanced care planning or starting conversations or getting to the nitty-gritty with life-sustaining treatments, I encourage you to seek that out and to practice some of the phrases that you might use. Next slide. So, you know, some ways that you might reach patients for palliative care can be easily identified. You can use some of those prognosis calculators or numerical indicators that we mentioned. The surprise question, as I said, is very appropriate. Measures of frailty are particularly helpful. Folks who suffer medically defined frailty are very, very appropriate for a palliative care evaluation. And the folks that have, you know, what is described as chronic failure to thrive due to multiple conditions are all appropriate for palliative care referral or potential evaluation for a hospice referral as well. And in going through that process of evaluating them and considering whether or not they might benefit from these additional or alternate services, you'll have the opportunity to learn much more about how they're coping with their disease and what's of essential importance to them as they navigate the final stages of their illness. Next slide. This is an example of a numerical predictor that can be used. Again, I never recommend one calculator over another. I think our clinical gestalt combined with what we know to be true about demographics and information that's based and relevant, you know, based in sound literature and also relevant for that particular patient is really particularly important. Next slide. So as I mentioned, this has been valued in the literature. If you answer no to this question, then you should be talking to that patient. Next slide. Frailty, as I mentioned, also very, very important predictor of morbidity and mortality. These folks do not do well. They don't tolerate intervention well, and identification of this group of patients really provides a very important opportunity to avoid quite burdensome, often ineffective care scenarios. Next slide. So they're at higher risk of death and morbidity and mortality. Well, that's redundant, but you know what I'm saying. They don't do well. You see them, so you know, and it's important to know on a deeper level what these patients are suffering from, that they do have frailty, and how that's going to impact their ability to tolerate dialysis and the related interventions. Next slide. So another way to think about identifying these patients is to have kind of a set of triggers. If any one of these things pops up, you want to have a response to that and a reflection about whether or not it's time to revisit the advanced care planning process or to discuss potentially palliative care or hospice care. The surprise question, acceleration of comorbid conditions, which may or may not be related to the kidney disease, poor prognosis, we talked about, increased frequency of hospitalizations. Boy, that's usually a really big tip-off that folks just are kind of not doing well with whatever's going on. Emotional withdrawal, loss of drive is important, failure to thrive, functional and advancing loss of function and advancing frailty, and of course admissions to skilled facility for assistance. All should be triggers that make us think, I wonder what else this patient needs to maximize their quality of life. I wonder if there are things we need to avoid. I wonder if it's time to reconsider what our care plan is, what our treatment plan is, how much longer we want to do dialysis, whether or not it's effective for this patient. How are we helping this patient to reach their personal goals? And are there things that person would want to avoid, such as dying in a hospital? Next slide. This is a flow chart that gives an example of what we just talked through. So at any given time, at the top box there, you're sort of checking with yourself and with the patient and the family and the medical team to see if the designated milestones are being achieved, and whether they are or they aren't, then you would go through the little care pathway there as indicated or as appropriate for the patient. But the important thing is that you're asking these questions, and that you're talking about taking a pause and reevaluating. Remember, we mentioned the kind of the conveyor belt that folks get on, where they just keep getting more and more care, and every time they need to go in the hospital, they always go back to the hospital, and every time they need a new something, they get a new thing. And often we don't take the time to say, well, I wonder if this is becoming less effective for the patient. I wonder if this intervention, hospitalization, whatever it may be, is going to help the patient to achieve a better quality of life or not, and what kind of a care plan do we want to develop? And maybe that care plan needs to change. So using time trials, milestones, and pause points can be really, really helpful in how to put framework around what's happening for the patient. Next slide. Oh, this is what we just said. So patients not deriving personal goal-directed benefits from dialysis therapy should be offered an opportunity to discuss withdrawal. So that seems to make sense, right, when you look at it. But on the other hand, we know that thinking about stopping dialysis really is terrifying for many, many patients. It is a life-sustaining treatment. In most cases, there would be impending death at some point in time, not too distant after discontinuing dialysis. And you know, as care providers in this space, it's really incumbent upon us to understand this landscape and to help our patients navigate it, because they are navigating it, and we should be supporting them through it. And there are ways to do this in a manner and with a process that is supportive of the patient, of the family, and this reference discusses that. Next slide. So where are we headed? We hope we're headed towards better care. We know that advanced care planning and the introduction of a palliative care focus can help us to achieve person-centered, value-driven care that's high quality and really more cost-effective, and it can reduce harms on many levels. We want patients and families and providers and systems to benefit by having better and more appropriate shared decision-making processes early on and late. And we all need to have the tools and the programs and the training to support that work. And that's one of the things that we at the Coalition hope to help with. Next slide. From a patient's perspective, you want to give them an opportunity to explore their wishes. That could be a kitchen table conversation with their loved ones, or it could be watching a video or reading a book or talking with their doctor, but just a chance to really think about their options. And then they would like to be able to give them an opportunity to express those wishes. That could be verbally to their care providers, to their trusted decision maker, to their to their agent, their healthcare agent. And so it could be written or verbal or other. And then in the end, we want everyone's wishes to be honored. But in order to have this happen on the patient side, we need a few other things. Next slide. This is what we need. We need to have communities that are aware of and understand what advanced care planning is and how it helps them, and what palliative care is, and what hospice is. So we need competent communities, we need public education, we need outreach, we need competent professionals. We need all of us to understand these processes, the importance of advanced care planning conversations, the legal aspects of the different forms, the advanced directive, the POLS form, et cetera, and to be skilled at facilitating even the most challenging conversations around life and death and life-sustaining treatment. And then lastly, we need the systems that we work in to support this work. There needs to be time in the workflow and the support to address issues. We need to have a way to document them, to store them, and to retrieve them so that that information is there at the time that we need it. And in order to achieve all those things together, we really need good public policy and common vision, and that's sort of the heart of what the Coalition for Compassionate Care is trying to support. Next slide. So what's your role? Really, I'm challenging you to be a champion for person-centered care. I really am. It's a call to action. I want you to support advanced care planning and end-of-life care planning for all your patients and for yourself and for your family. If you folks don't have an advanced directive and your healthcare agent doesn't have a copy of it, and you haven't had a discussion with them about what kinds of treatments you might want or not want, or what would be important to you, then you're behind the ball already. So I challenge you to do that. And I'd like for you to all understand what POLS is, really to focus on quality and validity when you're thinking about how to use that form with your patients. And remember that backup documentation and how important it is. Let's try to implement processes together so we can keep track of this information and have it available. Promote palliative care in your area, whatever that means. It might mean a professional palliative care board certified team, or it might mean a looser network of various care providers who are all interested in promoting patient care for those facing serious illness. And we want to know when and how to refer patients to palliative care and hospice, and to integrate advanced care planning, remembering that it's not a one-off, it's not a checkbox, it's not one size fits all, it's not even going to be the same process in different healthcare settings. But to find out what works well for you in your setting with your team and your tools, your resources. Next slide. So here's a list of a couple of websites we want to looking for resources on advanced care planning and other information about palliative care or advanced directives. And a lot of the stuff on these websites is, yes, you can download, or videos you can watch, tips and tricks for educating and talking about these topics. Next slide. That's it. So I would be more than happy to take any questions that have come up. And I'll just check in with Manuela at this point.
All right, guys, so if you do have any questions, please feel free to either unmute yourself or add them to the chat. Dr. Duncan, as of yet, we haven't received any questions. Guys, now is the opportunity to go ahead and ask.
Okay.
So don't be shy, this is Barb. I've talked to some of you and you do have questions about palliative care and palliative care versus hospice. Please, please take advantage of us having this guest speaker, Dr. Duncan, to get any questions that you have clarified. Okay, Dr. Duncan, I do see a comment about no questions, well put together presentation. When you guys report out at the end of June, I would like to know how you used this presentation in our hospitalization project, maybe how many patients you assessed or how many conversations you started. And let's go ahead and wrap it up if there are no other questions. We've kept you a couple minutes over. Thank you, Dr. Duncan, and everyone have a good day.
Thank you very much. My real pleasure to be here with you.